Ti he uri uri te he nako nako kātou hā whakatau ko rangi nui e tū I honei kātou hā whakatau ko papatū nuku e tā ko tō ake nei. Kātou hā whakatau ko te mātuku mai ra rotonga. Ko ia ruku hia manoa pau roto, ko ia ruku hia manoa pau wako. Kia tina whakatina. Te more I Hawaii e pupu ana hoki, e wāwau ana hoki, tā rewa tū ki te rangi, e ke pānuku, e ke tangaroa tau mai te mauri, au me ui e tā iki e. E ngā mane ngā reo e ngā karangaranga maho te motu. I taina mai o koutou waka, no te tai, toke rau mai te tai, haua uru mai te tai, rāwhiti. Whakawhiti atu te moana, o rau kaua, ki te waipounamu. Koutou rā, I taina mai o koutou waka, kei roto te whare nei, te whare wānanga o tākau ki pōneke, nau mai, hara mai, whakatau mai. Whakatauria mai ki tēnei kaupapa, ki tēnei rā, te tū hono hono, o ngā iwi take o Amerika. I taina mai o rātou whakaaro o rātou pūkenga, kei roto I te hauora. Ka tira, koena te wero no tērā taho o te ao. Ki a koe te rangatira, e te ahorangi, e Jeffrey, I taina mai tō waka no te iwi o Lakota, o tō rohe, mi taku ye o Yasin. Mi taku ye o Yasin. O tira, neira te mihi atu ki a koe, ki a kōrua, ki tō hōrangatira, I taina mai no te iwi a Navajo. Tēnā koe, tēnā kōrua, tēnā kōrua. Ki te iwi a Uhenuba, kia ora, nau mai, hara mai, whakatau mai. Whakatauria mai o koutou, tikanga o koutou kaupapa mō tēnei kōrero. Nō reira, hei whakapōpoto tēnei wahanga. O tira, he pounamu te wā, I taina mai tō waka ki konei, ki te tūtaki mai ki a tātou, ki a kōrua, ki te whakarongo, ki te mau te tikanga o tātou tūpuna. Ai, ka tikina mai ngā pūkenga o tēnā o te ao, kia whiri ai te huarahi tika, te huarahi pai mō tātou te iwi Māori, te iwi Pākehā rānei. Ka tira, kia kōrua, tēnā kōrua, tēnā kōrua, kia ora kōrua. He mea whakamutunga mō tēnei wahanga, ka tīmata te kōrero hei karakia mō tātou katoa, nō reira. Whakataka te hau ki te uru, whakataka te hau ki te tōnga. Kia mā kina ki uta, kia mā taratara ki tai, e hiake ana te ata kura, he tio, he huka, he hauhu, ti he mauri ora. Kia tau te rangi Mārie, kia hauho te rongo, kia kōtai ai tātou katoa, ai ake nei, ai. Ladies and gentlemen, from the far north, the east and west coast, across the Pacific, across the Cook Strait, I should say, from Te Waipounamu, from wherever you come, from those corners of Aotearoa, and to you, Jeffrey Henderson, and your hōrangatira, your partner who have come here to share your knowledge, your depth. We celebrate to be able to hear and to I guess to compare with our own journeys for what we are dealing with here in Aotearoa, New Zealand, and what things we may be able to learn from your lecture today. From the tribe of Ngāti Tō Rangatira, whom you had met this morning, mi taku ye o Yasin. In 1906, Chief Red Cloud gave an address to his people, and somehow or other that address ended up right sitting in front of my family on our marae out at Hongueka. And it was through a Lakota lady who had come over to share stories of the struggle, the plight of colonisation, and how we can minimise our disparities and inequities and prosper. So to you both, thank you and tēnā kōrua. On behalf of the University of Otago Wellington, we welcome you once, twice, thrice. Kia ora. Kia ora.
Tēnā koe toa. It's my pleasure to welcome our esteemed guest and to you, Patricia, as well. Dr. Geoffrey Henderson is a Lakota and enrolled member of the Cheyenne River Sioux tribe. In 1998, he founded the Black Hills Center for American Indian Health, which is a community-based non-profit research organisation. His mission is to enhance the wellness of American Indians through research, service, education, and philanthropy. It has been extremely successful, and it has gathered over $27 million of funding through more than 40 research grants and contracts, and provided jobs and benefits for more than 40 reservation tribal members. And injected over $5 million directly into reservation communities. So it's been a really contributive research centre. The centre is in Rapid City in South Dakota, which is in the Midwest of the United States, and it's between Pine Ridge and Standing Rock reservations, I believe, which are two places that we might have heard of here in Aotearoa. Dr. Henderson is going to present some data on cancer incidence, which is the very best cancer incidence data ever generated for American Indians and Alaska Natives. We understand here in Aotearoa the difficulties of producing high quality cancer data. It's been a mission for the last 20 years, improving ethnicity data and Māori cancer data, dealing with the misclassification of ethnicity, numerator-denominator bias, and ensuring our data sets are complete. So we really look forward to hearing how you've managed to do this in a very different context and with challenging data situations, and to hear about the variations in cancer for your people. Kia ora.
Lila Wopila Tonka, thank you very, very much for those beautiful, beautiful introductions. And before I begin, I want to acknowledge the original inhabitants of this land, their descendants, those both past, present, and future. For we think about the seventh generations, and that the actions we take today can strongly and vitally influence the descendants, our descendants, some 7 generations into the future. My name is Geoffrey Henderson, and it's a pleasure to be here. Thanks to those who have invited my wife and I to this beautiful land. Thank you so much for the opportunity, and for the opportunity to share with you. In my case, to share with you a relatively recent journey that I and others have made on the way to having a much better understanding of cancer incidence and mortality, although this is mainly incidence data I'll present today, for a large cross-section, not a complete cross-section of American Indians or Alaska Natives, but a rather considerable one. I'd like to speak about the implications of these findings, what I know to be some of the efforts that have followed up our publication of these findings, along with some conclusions with lessons for those of us who are interested in Indigenous and Aboriginal cancer. I have a number of individuals and institutions to acknowledge, and I also have no financial relationships to disclose for this presentation, although there are times that I wish I did have financial relationships to disclose, understanding what that means for some of our colleagues. Well, cancer data for our people and for many Indigenous people worldwide has been historically very problematic for a variety of different reasons and different by setting. One of the problems in the United States, though, was that data about us was subject to racial misclassification, This has been shown in lots of different data sets, all the way from cancer registry data as well as death data that we were conflated by high degrees of racial misclassification. It's also the case that we were very poorly represented in cancer surveillance efforts in the country. Many of you who are interested in cancer understand that it's the SEER, S-E-E-R, SEER cancer registry in the US that is sort of widely acknowledged as the gold standard for cancer registries, certainly in our part of the world and maybe throughout the world. And what we knew about cancer in Native people generally, is certainly in the 60s and 70s, stemmed from those of our relatives who were in the SEER data set. But unfortunately, it turns out we now understand that what that meant was it was mostly our relatives who lived in the southwest of the United States who were captured in the Arizona and New Mexico SEER registry. There were very few of us living in areas that were covered by any of the other 4 SEER cancer registry areas in the country. And so what that meant was many people commented that cancer was not a very significant problem among our people. And that was a pretty widely pervasive feeling in the 1970s, just as it was the feeling that coronary heart disease was not a very big issue in our people. And in another hat that I wear in my professional career is largely focused on cardiovascular disease. And I've been working with the Strong Heart Study since the start of my career in public health, which has done the most for us to define the rising tide of cardiovascular disease among American Indians, while it has slowly decreased significantly in our general population. But today's talk is about cancer. New linkage techniques, however, have greatly strengthened these data, and I'll be presenting these linked up data. And so what linkage techniques mean is the ability to harmonize and link together 1 or 2 or more databases. Ideally, these are representative databases. Ideally, they would be national databases. And ideally, there would be relatively little slippage in the linkage techniques. In other words, you wouldn't get out a jumbled mess of a lot of data that you would have to do a lot of heavy lifting to try to adjudicate or sort out. That is a problem with some linkage techniques. And it's less the techniques than it is what you start with as the quality of the data sets. However, what we, along with people with the Centers for Disease Control and our National Center for Health Statistics and National Cancer Institute, were able to do was to firstly combine the 3 major cancer registries that exist in the United States. SEER is one of them. The National Association of State Cancer Registries, or NACER, is another. And there's yet a third type of cancer registry that's in the country that is also felt to be very good SEER level quality registry. So the first job was to bring those 3 all together into one data set and then link it up, in our case, against the Indian Health Service Patient Registration Administrative Data Set. Many of you may know about our federal Indian Health Service. It provides care for about 2.4 million American Indians and Alaska Natives through 230 plus health centers, 41 hospitals throughout the United States. Of course, in the 2010 census, though, our Office of Management and Budget changed up the ascertainment or the reporting out of race and ethnicity in the United States in 2010. So the data aren't really greatly comparable to before that time, but it said that there were 5.1 million of us, either reporting that we were American Indian or Alaska Native alone or in combination with another race. So these data are going to tell us mostly about our population that are beneficiaries for the Indian Health Service, which generally means living on or very near one of our 250 odd reservations in the United States. These data, these incidence data, were published a while ago now in a special supplement to the journal Cancer. I was fortunate to be able to head the publication on prostate cancer incidence among our Native men. You might note here that these data were for the time period 1999 through 2004. These data have been updated now through 2016, through the end of 2016, although I don't have those here with me to share with you. But in terms of incidence, the picture is largely still the same as what I'm going to show you here. So the incidence hasn't changed a lot. There were a large number of tumor-specific as well as general cancer overall papers that were in this supplement. This is going to be a data-heavy talk, so any of you who are not familiar with data, do not be alarmed. I promise you, you are going to see probably some of the most complex tabular data you will ever have cast your eyes on, but you are going to absolutely wrap your arms around these data and have a great understanding of what it is that I'm showing by the time you leave here. So don't be alarmed. This is partly a presentation about the power of data, the usefulness of data, why it should interest us, why we need to pay attention to it. Here's a map of the United States. This shows all the Indian lands that are in the United States. They are shaded dark red against the orange that's here. And, you know, a couple things. You can see the Missouri River, or the Mississippi River, courses along here and down into here about. And most of us were all, if we lived on the East Coast in the 1600s and 1700s, as you know the history, we were all relocated west of the Mississippi River, and so most of our reservations are in the west of the country. It's also the case that the Indian Health Service is divided into 12 administrative regions. For the purpose of these analyses, we have aggregated multiple regions, with the exception of Alaska, into, for instance, the Northern Plains, what you're going to see called Northern Plains in these data tables. The Northern Plains here is actually the aggregate of the Billings area, the Aberdeen area, which is today called the Great Plains area, and the Bemidji area. Those three Indian Health Service areas are combined into the Northern Plains. East Coast, Southern Plains, Southwest, Pacific Coast, and Alaska. What this means, these red counties mean they're counties in which an Indian Health Service hospital or clinic exists, or are a county that is contiguous to a county in which an Indian Health Service clinic or hospital exists. And why this is important is because this defines who's a beneficiary for referral care in the Indian Health Service. The Indian Health Service is mostly about primary health care. If I need treatment, if I need chemotherapy for something, there's no Indian Health Service facility that can give it to me. I have to get referred off to the private regional hospital or cancer center, and the Indian Health Service will pay for that, or may pay. I'll be eligible to have them pay for it only if I live in a county, in the county in which the Indian Health Service is located, or in most cases, a contiguous county. So it's a peculiarity of beneficiary status. All right, so we've made this linkage procedure. Everybody's in this data set, non-Hispanic whites, blacks, Hispanics, everyone's in here, although for these comparisons that I'll be making, the comparator population are non-Hispanic whites. That's what NHW stands for. So here's all of us together, men, women, everyone together, the 50,000-foot view of this linked data. And we can see here that in those red areas called contract health service delivery areas, cancer other than skin cancer at all sites, we have a rate of 368.4 per 100,000. Non-Hispanic whites 475.9 for a rate ratio of 0.77. We have roughly 23% less cancer incidence at all sites other than skin cancers compared to whites if you were all lumped together. So yes, you know, at this level you'd say, well, yeah, there's no disparity here, there's no inequity here. However, when we look even at this level at several tumor-specific sites like kidney, 18.2 to 12.6 for a rate ratio of 1.45. Stomach cancer, 88% more, cervix, 28%, liver, 211%, gallbladder, 359% more gallbladder cancer in Native men and women. Incidentally, we have lots of diabetes. Diabetes is known to be a risk factor for fatty liver disease, for gallbladder disease. That may have something to do, but it's not clear that it does. And in fact, our NIH has just posted several funding announcements specifically for gallbladder disease in Native populations to get more attention paid to it than has been paid in the past. On the other hand, if you look at all of us, including our relatives who live on or near our reservations, and everyone else as well, they're all in this data set as well, right? Everyone living in the orange shaded areas on that map are in this linked up data set as well. Their rate is 275.5, so much less cancer than our relatives who are Indian Health Service beneficiaries. So who's not in this data set are Native people living in urban areas that have no Indian Health Service, people living in inter-region areas between reservations that fail to be a county with a IHS service or a contiguous county to that, and college students that are off at college. For the most part, so let's get into this. So this is incidence rates for cancer for males by IHS region: Northern Plains, Alaska, Southern Plains, Pacific Coast, East, Southwest. Here's all Native men together. Here's non-Hispanic white men. Here's cancer at all sites, and then the 8 leading types of cancer that men over this time period in this linked data set developed. Starting with prostate, lung, colorectal, kidney, bladder, non-Hodgkin's lymphoma, stomach, and oral. I have further done you the favor of shading the lowest value, which in this case is a rate, the lowest rate for any row, blue, and the highest rate, yellow. Now, among many Native people, we believe that before we were born, our spiritual embryos went on a journey to select the household, the situation that we would be born into. And if that were me, and my greatest concern was to live a life as free of cancer as possible, where, according to these data, should I have been born? In the Southwest. And where was I born? On the Northern Plains. Yes, on the Northern Plains. What you see here is that men overall, yep, we have a lower rate of cancer than white men overall. I could split each of these rows that have the region in it and show you the non-Hispanic white male rate for each of these rows. I could, those data are there. They're published in the journal articles, but it would make this too busy. Just understand that in any one of these tumor types, wherever the greatest spread between the highest and the lowest rate for non-Hispanic white men is, geographically, the greatest spread just did reach 30%. And it's true for women too, and we'll see the next slide. So 30% is the greatest spread from high to low that non-Hispanic white men in any region had for any tumor type or cancer overall. 30%. Take a look at some of these rates though. I mean, look at the rate at all sites. That alone is more than a 200% difference. Look at prostate. Oh, that's nearly a 300% difference. Look at lung cancer. That's almost a 600% difference in lung cancer rates. I mean, just look at all these, way in excess for most of them of 30%. Way, way in excess. I mean, this is profound geographic variation. There are a few other data sets that you can see demonstrated this level of variation. A couple other things for us to learn here. Look at the non-Hispanic white men. Do they lead with the lowest rate of any kind of cancer? They're beaten out by a group of Native men in some area, and in some cases multiple areas in every single one of these rows. In fact, they don't have the lowest rate of anything, but they do have the highest rate of bladder cancer. Let's take a look at women now. Here's women. Our Native women in this linked data set, again, have significantly lower cancer at all sites except skin cancer compared to non-Hispanic white women. Here we are broken out into our same geographic regions. And here again, we see mostly a monopolizing of the lowest rates in the Southwest, with the East Coast doing pretty well too, and the Pacific Coast pretty well too. And if we look back at the men, in fact, in none of these three regions did they ever have the highest rate of anything. Together, they all monopolized all the lowest rates of things. And the same's true, mostly true for the women. Northern Plains women, too, continue to have some high rates of cancer, but they're joined in this case by pretty high rates of cancer in Alaska Native women and a few by Southern Plains women. Here, too, again, if I showed you the non-Hispanic white women in these columns, they don't approach 30% of a difference as their maximal difference between high and low. And in this data set, you can still see 200, 300, 400, 500% differences in incidence rates for these 8 leading types of tumor that beset the women in this data set. Here too now, if we look at the white women, they have the highest rate of uterine cancer, but it's balanced out by their having the lowest rate of renal cell or kidney carcinoma. So in graphs with 18 rows, two graphs that have 18 rows looking at non-Hispanic white men and women, they have the highest rate of tumor types twice, but they only have the lowest rate of one once, kidney cell cancer in women. So what this does, I know for many of us now, this calls into question the appropriateness of using, in this case, non-Hispanic whites as the comparator or the referent population. And I know I heard at the Oceania Tobacco Conference last week in Hobart a little bit of talk about proper referent populations to use as well. You know, in the fact that as Indigenous people, I'm not sure about about the feelings here, but I know in the U.S. we're not too keen to compare us to one another. In fact, we're really not too keen to do these types of comparisons at all. It somehow argues that you could say a lot of things our colonization experience was worse than yours. our Holocaust was worse than yours. You know, you can make these sort of leap assertions, which I've seen happen when, for instance, we're comparing ourselves against African Americans, for instance. Well, you might wonder, so how low are they? You know, yeah, well, the other thing I need to, the other thing I need to say is, before I go into describe this, I've heard it said, and I believe that these types of data are mostly represent tragic stories and tragic lived experiences with the tears washed off of them. That's what these type of data are. So, my father-in-law passed away with non-Hodgkin's lymphoma here a couple of years ago. In each and every case that cancer has, affected a Pacific Coast, East, or Southwest Native family, it's difficult, it's often tragic, and it should concern us. So, in some way, taking this look at, however, this look at the data in this way is very, very instructive. I mean, what dramatic more texture to these data were generated through this versus sifting through 20-year-old manuscripts published off of the SEER database in the Southwest. These data are useful for identifying certain issues that we should focus on. These data are also very important for us for establishing a baseline for surveillance moving forward. We may think about data differently. However, in our future, as you drive toward a smoke-free New Zealand by 2025, you should reasonably expect to see significant declines in lung cancer, for instance. You'd like to see the benefit of that decline shared equitably across your populations. You won't know whether or not that's true unless you have really good quality data like these to serve as your base, either baseline or time frame. Well, how good are these data? So, I went searching around the world. Countries in this world, I mean, those of us in the United States and Australia and here in New Zealand and Canada as well, we have pretty good functioning data systems. We generate really generally pretty good data, but across the rest of the country, it is really spotty how good data systems that they have. And comparison data internationally is really difficult to come by. I spent a good long time trying to contextualize these data, both high and low, against the highest and the lowest examples that we saw in throughout the world for these tumor types. And what you can see is that for lung, well, for lung especially, though, is really breast is not looking too bad either. Thai women have an extraordinarily low rate of breast cancer, incidence rate for breast cancer. And in fact, it wasn't clear to me in the literature that people understand why that is that low. It's felt that Thailand does have a pretty good data system, though, and that we can believe in that figure, but that is really, really low. So these data, on both sides of the ball of the equation, compare with both the lowest and the highest rates of cancer in the world. Well, so, of course, this begs the question, why does this variation exist? Tobacco use certainly relates to several of the cancers. It may relate to more of them than we previously recognized as being strongly linked to smoking, like colorectal cancer, for instance. But lung, head and neck, aerodigestive, and bladder cancer especially are known to be linked to tobacco use. But we've done some ad hoc or post hoc analyses to show that tobacco use does not account for this. It does not account for the bulk of the disparity in lung cancer incidence rates. For instance, smoking rates in the Southwest are 17% plus or minus 1, while our latest data shows 42% plus or minus 2 on the Northern Plains. So that's about a threefold difference, slightly less than a threefold difference in smoking rates, but yet, as we saw, there's a 600% difference in lung cancer rates. That calls into question other factors besides smoking that are very unexplored so far. The other thing that this should cause us to believe or to think is that there may be a previously undocumented or unappreciated protective factor at work, especially in the Southwest and perhaps in the East and the Pacific coasts as well. Now, this causes us to have a paradigm shift in our thinking, because the search for protective factors is an asset-based or a strength-based approach versus the typical deficit-based approach that is most often employed, especially with these kind of data. What could that be? So some researchers at Northern Arizona University have suggested blue cornmeal could be a difference. Blue cornmeal is consumed quite pervasively across the Southwest by most of the tribes in the Southwest. It's totally absent in the Northern Plains, except for Frito-Lay blue corn tortilla chips that are sold up there. But we haven't historically consumed blue cornmeal, and there's research going on in Northern Arizona to look at the possible protective effect of blue cornmeal. Research is desperately needed to follow up these findings. There's certainly genetic differences that could be at play, epigenetic differences that could be at play here. Some of you might have seen in the literature a discussion about the anti-cancer properties of metformin. That's looking very interesting, especially with regard to breast cancer and endometrial cancer. And what those data show at this point anyway, we need more data to take a look at this, is that you actually do worse with cancer if you're taking metformin before you get your cancer diagnosis. But when metformin is started after your cancer diagnosis, you do much better. In breast cancer, you do 50% worse if you're taking metformin prior to diagnosis, but you do 30% better survival if you begin it after your diagnosis. Very interesting. Could there be differences in metformin use over the past several decades between the Northern Plains and the Southwest? I don't think so. As a clinician myself, prescribing metformin on the Northern Plains, I don't think that it could be. But it could be, and it could also be the case that could be a gene-environment interaction also. As I mentioned, what these data show us, and then one of the lessons in these data, in addition to the lesson about appropriateness of referent populations, is that these are the perfect kind of data to afford us the opportunity to change our perspective from deficit-based to an asset-based one. Well, speaking of cancer overall, where can policy help us out? As we've heard in our visit this morning to the Maori Health Center south of here, that the clinical environment is a key policy target. It's a key policy target for ascertaining smokers and intervening in the path or the journey of an addicted smoker. It's also certainly policy for cancer screening for the screenable cancers is subject to policy-related approaches. The provision of care, of course, can also be subject to change through policy to better incentivize any kinds of outcomes that we might be interested in, including cancer in Indigenous or Aboriginal populations. This includes both our Indian Health Service as well as other federal government targets. In the United States, the Affordable Care Act, which is under assail right now by the new administration, also, though, contains never-before-seen emphases on preventive measures and support for those measures. I previously mentioned metformin. The broader environment is also a key policy area. We work with researchers at the University of New Mexico who've been working on Navajo Nation for the last 15 years because of the fact that 60% of the 300,000 plus population living on the Navajo Nation live within 10 kilometers of the 110 abandoned mines that exist on the Navajo Nation, each with their big heavy metal laden water storage pools on them, each with a history of uranium and other radiologic mining activities, as well as the workers who work there. Many of the Superfund sites in the United States are located in very near close proximity to tribal populations in the US. This is a workers' safety issue too. The issue of smoking, of course, is a workers' safety issue as well. In the United States, laws that are passed by our states do not apply to our federally recognized tribes. So smoke-free policies, for instance, do not apply to the reservation, to any one of the 250 plus reservations that are in the US. And so work is needed, and we're doing a lot of this work with the populations we work with to try to get them to take on and implement smoke-free policies, for instance, that we've enjoyed in our states now for 15 years, I suppose. Well, in conclusion, so I've shown you, and hopefully each of you can appreciate the profound degree of geographic variation that Native men and women in the United States have. This variation should be taken into account in both policy and surveillance efforts, and I mentioned we've updated, we reran these linkage techniques through the end of 2016. We 2 years ago published the mortality data, which was through 2011 in a special supplement to the American Journal of Public Health. But we're recomprising our public-private partnership to republish these incidence data, I believe through the end of 2016. They're being cleaned right now. We understand, it's speaking to the choir here, but there are many individuals many influences on both individual and population level health for us to focus on. There's many potential policy levers that we could deploy as we work to combat and lessen cancer. Dissemination and implementation is a big issue. I'm not sure that's a real big buzzword in the US right now, D&I, or dissemination and implementation, the idea that we shouldn't have to continually reinvent the wheel every time we're in a new context. Although I will say at the same time, the work that my wife and I do at our center in Western South Dakota is often, job one is to culturally tailor the intervention first. For the in our case, the tribal partners. So there is a little bit of having to do that. You know, an ongoing surveillance is just critical for us. It's not only critical for cancer, it's critical for diabetes, critical for cardiovascular disease, critical for maternal and child health, and all manner and number of other things that you can think of. We'd like to know that when we decide to act in a certain policy direction, that it is based upon, excellent, sound data, and that we equally pay attention to the mechanisms that we're going to need rolling out into the future on the surveillance side of things. We believe that greater participation on the part of our tribes is, just as well as you have obviously agreed to, that greater participation on the part of, in your case, the Maori, is essential to work in this area, and essential to devise and develop effective strategies and the effective ways forward to help lessen the burden of cancer in our communities. This is how you can contact me. And I wish to thank you very much.
Sure. Thank you very much, Geoffrey. That was a fantastic talk. And we've got time for questions or comments from the floor. Elder, we have to use the mic, sorry, because we're on the webinar.
Yeah, thank you very much for your presentation. If I make a couple of comments, I've noticed there's hardly any infectious-related cancers among the top 8 rather. I'm not sure about, it's very, as compared to other indigenous populations in developing countries. And also the idea of looking at a protective factor among the Southwest, is it easier to look at risk factor rather in the northern part as compared to the southern protective factors, given you mentioned something like mines and the uranium and things like that? And the last thing is about terminology. I'm not sure what's the difference between Alaska Natives and American Indians in terminology.
Excellent questions. Thank you for those. I'll just set this up for background for us. You mentioned, I think your point is a relative lack of infectious causes of tumor types that are shown here. Well, of course, these are the 8 leading tumor types. All the rest of the non-skin cell tumor types are there. Where they would array, if I would have the top 25, for instance, in a table, I'm not sure how that would look. That's a good point, though. There is a lot of interest in the relationship between infections, both acute and chronic infections, and cancer, in the development of cancer, or the pro-cancer strategies that some of these infectious agents do have. And the second point about the, looking at protective factors, we have the behavioral risk factor and systematic surveillance effort in our country, BRFS, it's called, BRFSS. And it's run by the states, all 50 states, and they do random digit telephone dialing of the populations. They're supposed to be representative, and I think for the most part that they are, and they ascertain risk factors, prominent risk factors in the country. Some of in our mortality publication in the American Journal of Public Health from a couple years ago, some of those BRFS data were brought into the analysis of the mortality data in an attempt to try to control for the kind of risk factors that you might be wondering about. 2 things. Firstly, there's a lot of discussion worldwide now about the relationship between obesity and overweightness and cancer, and diabetes and cancer. The highest rates of obesity and overweightness and type 2 diabetes in the United States are in the Southwest. Number one. About the, so what kind of a, what kind of a study could reasonably make reasonable inroads at identifying a potential perspective or a protective factor? I think it needs to probably be a case control design. It's going to need to be a full omics approach. It's going to need to look at DNA, RNA, protein, and microbiome, in addition to state-of-the-art phenotypic measurements. And even then, the numbers needed for breast cancer, for instance, if we had 2 cohort of breast cancer women, native and non-native, one in the Northern Plains, one in the Southwest, for instance, I think we'd need 250 per arm in each of the 2 sites, which would take a long time to accrue, which would cost a fortune, in which I'm unlikely to get funded by our National Institutes of Health. So, but we're highly collaborative. We do work in a community-based setting. I mean, we're basically doing academic work in a community-based setting, but we collaborate very highly with colleagues in academic settings. Some of our larger cancer centers in the country potentially, maybe the one in Utah, maybe the one in Seattle, they potentially could reasonably accrue that type of a cohort to examine. But we're still working on that. And differences in Alaska, of course, in Alaska has lots of tobacco use. Alaska has even greater amounts of daily nicotine intake for a daily smoker or daily nicotine consumer, because they have many, I'm going to forget the name for it. Do you remember, Patricia? ICMIC? Yeah, ICMIC. They have ICMIC, which is like a fermented form of nicotine, nicotine-laced, it's a fungus that has astounding levels of nicotine in it. And so there's some of our other colleagues are doing quite a bit of work, especially work among pregnant Alaska Native women. In Alaska, in some groups, women actually start smoking when they become pregnant. They were non-smokers prior to becoming pregnant, but for cultural reasons, they start smoking after they learn that they're pregnant. And, I wondered if the same wasn't happening here, because we saw data in Hobart last week to suggest that 45% of Maori women smoke. And that seems unusually high compared to what the daily rates of smoking even would be. Is it the case that many women here too are starting to smoke for a variety of different reasons when they learn that they're pregnant? On the other hand, Alaska has much more subsistence consumers who live off the land and consume way more omega-3 fatty acids in their diet than we do, for instance. So it's a real mixed picture there. It's still very confusing, and it's, if you're a researcher, you can sort of just imagine what it might take to begin to disentangle these relationships and these data. Yes.
Thank you so much for your presentation. It's wonderful to have you here. I have 2 questions. The first question having to do with alcoholism, and was that looked at as a contributing factor to the variations? And then thinking about my own experience in working in healthcare in the US, particularly with Medicare and Medicaid, one of the things that I was thinking a lot about in the variation is the provider networks that are available in the different regions and what that would look like in terms of referral networks. And just remembering just how challenging it is in the Northern Plains in terms of having viable provider networks for specialty care. And I'm wondering if there may be a protective factor relating to overall access to healthcare, and the Southwest having much stronger provider networks. So then, whether that's epigenetic interactions or not, or something else, that people's systems are then bolstered and less likely to see incidence of cancer because of better access to care.
Mm-hmm. Good questions. You know, with respect to alcohol consumption, between the Northern Plains, the Southwest, the Southern Plains, and in many areas of Alaska, alcohol consumption patterns are about the same. The level of dependent drinking, the level of binge drinking is very comparable. And where we get the clearest picture that this is the case is from the BRFIS data. Now, on the other hand, you know, BRFIS is telephone, and not all of our people have landlines. BRFIS doesn't generally call cell phones. So that's an issue. You know, it's also the case that, well, you know, while we're talking about alcohol, we should also acknowledge that when you ask members of our population in the US, have you ever drank? Has alcohol ever crossed your lips? About 34% of Native men and women will say no, alcohol has never crossed my lips, when that figure's about 14% in the general population. Only a few religious denominations have lower rates or have higher rates of having never drank, Seventh-day Adventist and one more that I'm skipping on right now. Mormon, maybe. But so we're the highest, you know, surprise, tribal people are the highest teetotalers in the land. But among those of us who do drink, it's characterized by much more harmful styles of drinking. Remind me your second?
The second question was about provider network.
Oh, yeah. In our mortality papers published in the American Journal of Public Health a few years ago, several of our writing groups that looked around amenable death due to amenable causes, and another publication did look at driving distance to nearest healthcare facility. It didn't seem to figure into differences that they saw in mortality between members of these areas. I haven't spent a lot of time on Navajo Nation as well as my Lakota reservations in South Dakota. You can be good, and you can find yourself good in the middle of nowhere in both settings pretty readily. This is, and you know, additionally, this is the Indian Health Service. Everyone in here is a beneficiary of the Indian Health Service. You don't pay a copay when you go to see our Indian Health Service. However, what you need when you develop cancer, you need them to pay for referral care for you. Our facilities run on the October 1st federal fiscal cycle, and the joke in Indian country is that if you're going to break your leg or have something serious happen to you, you'd better have it happen to you in March or earlier, because by the end of March and any time thereafter, the facility will have exhausted its contract healthcare funding line item in their budget to be able to pay for you to get what you need to get. That's pretty common across the whole system, unfortunately. You know, as mentioned to somebody earlier, you know, again, if you want to know the level of the inequity in the funding, we spend about $9,500 US per year on every person incarcerated in our federal penitentiaries. Federal prisoners, $9,500 a year on their health care. What do we spend for Native men and women through the Indian Health Service? The high estimate is $3,250. What do we spend for Medicaid? You know, a Medicaid recipient in the US, about 8,000. Medicare, over 12,000. VA, they're about 8,000 a year. Native men and women, 3,250. That's a high estimate. It's probably in some areas, there's even inequitable funding across our areas. So, yeah, good questions. Interesting issues. Other questions?
I think we might need to close off.
Oh.
Thank you very much. Great questions. What an incredibly stark funding disparity that is. And so thank you very much for showing us the power of data and the geographical variations. Here in New Zealand, we've got quite significant variations in life expectancy for Māori in regions in the north compared to the South Island, and the gaps between Māori and non-Māori are closer in the South Island, and there's not so much variation in life expectancy for non-Māori. So this raises really interesting questions about, I know that your country's large and the environment differences will be different, but it helps us maybe look towards looking at geographic variations here too. So thank you very much indeed for coming all the way over here and sharing your interesting research with us, and lots of ideas for further research and policy. Kia ora.